Hello, welcome to the Leapfrog webinar on safe indoor air. I'm Patrice Brown, the Chief Operating Officer of the Leapfrog Group. Today, we are bringing together leading air quality and infectious disease experts to discuss engineering guidance for reducing infectious aerosol exposure. Interventions will be discussed in the context of events such as the COVID-19 pandemic and opportunities for providing protective engineering design elements applicable to endemic diseases with infectious aerosol dissemination potential. A few notes on housekeeping. We will answer as many questions as possible, so please post your questions in the chat. At the end of the webinar, we will post an event survey in the chat. Please do the survey. We'll send out copies of the presentations later this week. Let's get started. Our panelists today are Dr. Stephanie Taylor, CEO and founder of Building for Health, Inc. She graduated from Harvard Medical School and practiced clinical medicine for decades. She returned to school to get her master's in architecture and then designed hospitals for almost a decade. Her subsequent research has revealed that managing the indoor environment, and especially indoor air quality, is a powerful driver of patient healing or lack of healing. Ken Mead and Stephen Martin are research engineers from the Centers for Disease Control and Prevention's National Institute of Occupational Safety and Health. Ken and Steve have decades of experience in the topics of ventilation design and exposure control, predominantly in the areas of healthcare and infectious aerosols. In addition to their roles at the CDC, both are actively involved in multiple Ashrae technical and standards committees focused on healthcare design and air treatment technologies. In addition, we have Frederick Hendrickson, co-founder and US CEO of Renzair. Renzair specializes in providing indoor air quality solutions that meet the highest standards, drawing on its long experience in dealing with the healthcare sector. After a career in financial services, Frederick, along with his twin brother and fellow co-founder Christian, have expanded the company's operations in Europe, North America, and Asia to meet commercial demand driven by a new heightened focus on indoor air quality across the globe. Frederick is a Danish national resident in the US. He has a BS in international business and an MS in finance and accounting from Copenhagen Business School. Welcome to our panelists. We will first get started with Stephanie.
Great, thank you so much. I am totally honored to be a part of this panel. I've been aware of Leapfrog for over a decade, and I reached out, screwed up my courage and reached out to the president, Leah, about 8 years ago, and have been sort of working peripherally with Leapfrog since then. So I'm really excited to be here. So to get going, because we all only have a few minutes, I want to talk about my work that has made me clearly convinced that buildings, in fact, are our best medicine. And this is important for all of us, but it's especially important for patients in hospitals. So, shoot, I can get my. So again, I'm a physician of a long, long time. I still work at Harvard Med School and doing infection prevention consulting. I love Ashrae, work a lot with Ashrae, and now I have this company, Building for Health. I do not work alone. This is just a shout out to some of my colleagues, Dr. Tassi, Dr. Finkelstein, and the other folks you see listed. So my journey to you as a physician really started when I was in med school. I was in my 20s. This is me. I needed to have an adventure. I had been studying all the time. So I decided to go to Papua New Guinea for 4 months and practice medicine. And I was stationed in this hospital, the WEWAC General Hospital in PNG. And if you look at it, at least as I looked at it back as a medical student, I was really worried about the patient outcomes. You can see in the men's tuberculosis ward, the concrete floors were dirty. There was ventilation, but the beds were close together. So there were a lot of things that I thought were risk factors. In the operating room on the right, we wore flip-flops on our feet. The surgical nurses didn't wear gloves. And I thought, oh my gosh, these poor people are never going to go home without a terrible infection. But in fact, they did quite well. And then I went back to Boston to the Harvard teaching hospitals where the rooms looked fantastic in terms of surface hygiene, single rooms, private bathrooms. And yet the epidemic of healthcare associated infections was really scary. And these weren't just numbers. These are real people who come in with a ski injury, with leukemia and are challenged by an infection. And my mentor in med school, Dr. Judah Folkman, if anyone can be a mentor, be a mentor. They're critically important. But Dr. Folkman told me, never underestimate the role of the environment. So it took me about 20 years of medical practice before I went back to school, got my master's in architecture to really look at how we could bring together these two professional silos. Building management, where we were focusing on energy, avoiding climatic disasters, following best practices. And then medicine, on the other hand, we want to heal our patients, we want to follow protocols, we don't want to get sued. But how do we bring these areas together and make human health the key to building management and indoor air quality management? So that's what I want to talk to you about for another 4 minutes or so. So how do we do that? So in my opinion, we need to move beyond the metrics that we monitor indoors that are really focused on HVAC systems around, for example, energy savings, looking at particle and gas concentration, temperature, humidity, air changes, pressurization, and moving and including in those metrics, monitoring things that apply to human health that are affected by the indoor environment. So for example, how does the indoor air quality affect your immune system, inflammation, cognition, even metabolism? Things like diabetes, type 1 and type 2 are to some degree influenced by the indoor environment. And then what happens to indoor air quality and the microbiome, the community of viruses, bacteria, and fungi that live in a building and on our bodies? And by the way, most organisms that live on us and in us are good for us, but clearly not all of them are, or we wouldn't be have been struggling with the pandemic. So how do we bring all of these metrics together in a way that's understandable and actionable? So to do this, what I've been doing is having identified 11 indoor metrics that are key for human health. The top image shows a cell membrane. I think it's amazingly beautiful. You can see polar and non-polar regions in a cell membrane. The question is, how do we quantify the biological effect of exposure to things that are in the air? So particles of different sizes, both biological particles and abiotic particles, gases, things that are modulated by thermal conditions, and then quantifying the penetration of those compounds and then the consequent effect on your organs. And these changes start occurring in minutes, not hours, not days, but very quickly. So what I've been doing is taking those 11 metrics, monitoring the indoor environment continuously, relating the concentrations that we find to human health, and then giving you feedback, a dashboard that shows what your index is and what remediation steps might be. And I'm really proud to say that the Leapfrog office has been monitoring their indoor environment, and it's been excellent across the board. And I hope that continues into the winter. So we take all these indoor metrics, we evaluate not only the primary compounds impact on your body, but the interaction of these compounds on changes to your immune system, how deeply your tissues would penetrate, what genetic disruptions occur, and epigenetic changes, and then what happens to the infectivity of microbes. So the one case study I'm going to show you was actually done not by Building for Health, but by Phoenix Controls and Global Consulting, where they monitored, I've been working with them as well, but this is their study. They monitored the full consortium of metrics that I talked about. They created a dashboard for each operating room. And within the suite of operating rooms, they were able to show if an operating room were optimized for surgery, for patient outcomes, that would be the green ones. If it was not, if the operating room was not quite ready, or if it definitely should be avoided at that moment. And in their case study, this one's at the Methodist Hospital. When they had this monitoring system in place, they reduced surgical site infections from 3.8% to 0.5%, which is huge. They also saved, there was a tremendous energy savings as well, based on how they manage the environment. But I'm not going to talk about that right now. But you can see, so they extrapolated the savings based on published numbers, published costs. But whatever the cost, cost to the hospital, direct costs, indirect costs, just looking at the human suffering and the avoidance of suffering, they made a huge impact on reducing infections by managing the environment. I mean, why do we have buildings? Yes, we want them to protect us from climactic events. Yes, we definitely need buildings to be energy efficient. But now we need to focus on optimizing human health through environmental exposures indoors. I'm sure most people have heard we're indoors 90% of the time. So the indoor environment is our primary exposure. So we've really got to relate what goes on indoors, and I think indoor air is the most impactful component, to human health. And by giving visibility to the health impact of the indoor environment, we have a scientific basis for managing indoor air quality to actually support our health. Thanks a lot. And there's my contact info if you want to be in touch. I think I didn't even go over. So thank you.
Thank you, Stephanie. I think you've set the stage for the rest of the discussion now to really understand kind of why indoor air quality is important. And with that, I will turn it over to Ken.
You're on mute, Ken.
It's only been 2.5 years, 3 years. Anyways, sorry about that. Okay, thank you for the introduction. Yeah, I'm going to give a really rapid overview of CDC's ventilation and buildings guidance. I apologize for the speed of it. Normally this is a longer presentation, but what I want to do was give a high-level overview. There are links in the presentation that I know you'll get copies of later, and you can follow those links if you want to take any of those topics into a deeper dive. And it's not letting me advance. Make sure this. Okay. Can you see the second slide? All right.
Yes.
Okay, great. All right. So the first thing I want to say, and perhaps the most important, is do not get distracted by terminology. There are a lot of different professions that are talking about this issue of infectious aerosols or COVID aerosols, and we don't always use the same terminology. So aerosol scientists, engineers, industrial hygienists, whether we're talking about aerosols, whether we're talking about particles, whether someone's calling about a droplet, the bottom line is if it's small enough to float in the air for any reasonable amount of time, then it's going to be impacted by the airflow while it's in the air. So even if you look at the slide shot on the right, you see that 10 micron particle, which some entities would say, oh, that's a large droplet, right? It's going to fall. You probably read that it fell immediately from the sky. Well, aerosol science tells us that that's not exactly correct. It's going to float around for a few minutes. In this case, 8.2 minutes under the conditions there on the slide. And so if there's a room current going on, then it's going to follow that current to some extent for those 8.2 minutes. So that's the important part here to recognize, is that airflow has the potential to be protective, or it could actually be harmful if it's flowing the wrong direction. The CDC ventilation and buildings guidance is at the link you see there. And of course, it's part of CDC recommends this layered approach to reduce exposures to SARS. This gentleman here, Dr. McKay, uses the Swiss cheese visual model to describe that. And different slices of cheese may be in and out of your model based on what the circumstances are on the ground. You know, right now there's a little bit less emphasis on physical distancing and masks for many indoor environments. But yet, if you're a healthcare indoor environment, your situation is different, and maybe you're still going to have physical distancing and mask emphasized. So this is a flexible model that looks at multiple pathways to try to protect inside occupants. Outdoors, even a light 1 mile per hour wind can be very protective. You know, 1 mile per hour, that's nothing. You will not feel 1 mile per hour outdoor. You'll talk about how dead the air is. But yet 1 mile per hour is 88 feet per minute. And that's approximately the same protective airflow that's used at the intake to a laboratory fume hood. So it works very well in rapidly reducing airborne contaminant concentration. What about when we go indoors? Well, we have to create whatever that protective airflow is going to be. And so we can use protective ventilation practices and interventions to reduce the airborne concentrations of the virus. Sorry about that. One of the first things that we've tried to emphasize throughout the pandemic is, are you code compliant? And so if we step outside of those prescriptive areas within healthcare where we have protective airflow paradigms because we have known infectious aerosol generators in them, then that often takes us into the area of Ashrae standard 62.1, ventilation for acceptable indoor air quality. Code compliant, as we refer to it, aligns with the year the building was constructed or most recently renovated or upgraded. It applies to the outdoor air percentage of the HVAC delivery only, so it's not the total airflow. And at a minimum, we've encouraged people, if they are considering upgrading, that they take their current system and bring it up to the current code. If they're living in a 25, 30-year-old building, the code at that time may not be as protective as it is now. We feel like this establishes a strong baseline from what you're going to consider what additional interventions you might consider invoking. Ventilation system upgrades or improvements can increase the delivery of clean air and dilute potential contaminants. You may need to get experienced HVAC professionals involved in your consultation. The CDC guidance presents a list of ventilation interventions that we call tools in the mitigation toolbox. It's important to know each tool can contribute towards a reduction in risk, so you can use multiple tools. You aren't expected to use all of them at the same time, and which ones you use and when you use them can vary based on conditions. Using the tools reduces the risk of exposure to the virus and the subsequent spread of disease, but it's not going to make it totally disappear. Tools can be universally applied across indoor environments. Choosing which tools to apply can be challenging. The specific combination of tools at any point in time can change, and the building owner and operator should identify which exposure reduction tools are appropriate for each building throughout the year. In addition to buildings, the tools can also be used for transportation vehicles. Going into a quick review of some of the tools, important to note out that we did not make these up all on our own. Ashrae has similar recommendations on their own site. Not all interventions are going to work in all scenarios, and your local conditions are going to drive the approach. You've probably heard me say that a few times by now, and there's a reason for that. It's an important concept. One of the easiest ways, if you have an emergency scenario and you need to get immediate relief, is to open windows and doors. When the weather allows, increasing outdoor airflow, even if it's only slightly open, it can still be protective. Of course, you're not going to do so if it's going to introduce a safety or a health risk. You can use fans to increase the efficacy of those open windows or doors. Use the fan in an exhaust mode. So it's pulling one fan in exhaust mode in one window can pull air in all of your other windows, even if they're only cracked a little bit, and help improve the flushing of the air in that room. You can get similar results in larger spaces if you have larger fans, gable fans, roof ventilators, or whatever you may have in that space. You can add outdoor air through your system's HVAC system by adjusting the outdoor air dampers. In most scenarios, you can eliminate or reduce, or you use this tool to eliminate or reduce HVAC air recirculation. It's not going to affect thermal comfort during mild weather. It's going to be a little bit more difficult during hot, cold, or humid weather, and may require HVAC consultation in those scenarios, especially in very cold weather. You do not want to freeze your coils. Increasing air filtration to as high as possible without significantly reducing design airflow is another intervention. Increased filtration efficiency, especially helpful if it's more difficult to increase your outdoor air. So the point being, if I'm cleaning my air with a filter, then perhaps my reliance on needing to open windows becomes less because that filter is doing the work for me, and vice versa. If you go that route, though, inspect the filter housing racks and make sure that the appropriate filter fit and minimize that the fact that air might bypass through the filter, and that's what's shown in the little graphic on the right. More HVAC recommendations: ensure that your systems are operating properly and provide acceptable indoor air quality for occupants. Rebalance or adjust systems to increase total airflow to the occupied spaces. This is especially important during occupancy. If you have a variable air volume system or an occupancy triggered HVAC system, you want to make sure that that's not shutting down the airflow when periods of occupancy are occurring or when there may be contaminant generation. For simple systems, that's as easy as taking your thermostat and putting the fan in the on mode so that airflow continues to pass by that filter and get cleaned. Other exhaust fans in the building during occupancy might also be operated. I'm talking about bathroom exhaust fans that sometimes some systems you see they're only triggered when the room's occupied. Well, you know, there's still some contaminant going on after that occupancy lives that's floating around in that room. So let's allow those fans to keep blowing and to keep exhausting air from that room, at least for a while after occupancy, and that'll help flush that air out. You can also get protective air flushing by keeping a kitchen and exhaust system fans running longer than you might normally otherwise. Consider the use of portable HEPA fan infiltration systems. These systems provide additional air cleaning and especially useful in higher risk areas. Examples like a workplace medical clinic in the waiting room, for instance, areas frequently occupied by people with a higher likelihood of having COVID-19 and or an increased risk of getting COVID-19. And that applies for any respiratory disease, really. Portable air cleaners that use filters less efficient than HEPA filters can also contribute to room air cleaning, and Steve will talk a little bit more about that later in his section. Generating clean to less clean air movement. This is one of the more questions or areas that we've had a little bit more questions on. What we're really talking about here is being strategic. Where is the air going to leave the room? Where is it going to enter the room? And the graphic you see on the right, we have a dental chair. The dental patient is the source of potential infectious aerosols. And what we're saying is we're using a recirculatory HEPA system to establish an airflow within that space. The contaminated air goes in at the foot, it comes up, it gets cleaned, and it comes out at the top behind the patient, and you create this circular pattern that quickly controls what happens to those infectious aerosols after they're generated, prevents them from going around the entire room. You can do the same thing with your central HVAC, especially if you have a ceiling grid type system that allows you to position your supply and return. You can do similar strategies. Think about things like the reception desk or the check-in desk at a healthcare facility, for instance. You might have it so your airflow is your clean air is coming in from behind the receptionist and going out across towards the waiting area. For portable HEPA units, you can do this a little bit easier if you have flexible ductwork connections. You can also augment the airflow directions using partitions. We have a recommendation to consider using ultraviolet germicidal radiation, sometimes called germicidal ultraviolet. It should not be used alone. It's a supplemental treatment to activate SARS-CoV-2 that's in the air. It's especially useful if options for increasing your room ventilation and filtration are limited. There's three basic types. Right now, CDC is putting more emphasis on using upper room systems and induct systems. Far UV systems is an emerging technology. And again, Dr. Martin's going to talk more about that. Steve is really our CDC's UVGI principal expert, and he'll talk about that in his section of the presentation. Air flushing, if you have rooms that go through occupancies of periods of higher occupancy and then less occupancy, if you can continue to flush that room and get rid of the contaminant faster, then it will make it safer for subsequent people coming into the room. A little bit less applicable to residential applications, but more so in an occupied non-residential setting. We put some cost estimates down. These are first cost primarily, but it's important to consider that all interventions have both the first cost as well as an ongoing or operating cost. First cost for things like opening windows and doing your inspections and disabling demand controlled ventilations through the flip of a switch. Those are generally free interventions that you can invoke rather quickly and at minimal cost. Less than $100 using fans to augment, opening windows, repositioning supply. Portable HEPA systems, approximately $500. The price of those has actually come down quite a bit as the pandemic has progressed. And then a UVGI system, a ballpark $1,500 to $2,500 per fixture. Now, if you look at those same units though, and look at operating costs, obviously there are operating costs with opening windows if it's causing you to have to treat more outdoor air and temper it more, depending on what your ambient environment is about. There's energy costs associated with operating fans and Hepa systems, as well as other impacts such as noise that might be generated from those. UVGI, on the other hand, while it had a higher first cost, its operating cost is actually very low, and you're treating multiple people in a larger space, so your dollar per square foot of clean air, so to speak, becomes cheaper over the long haul. And so with that, I'm going to hand it over to Steve, and Steve's going to continue on.
Thanks, Ken. I hope you, and this is not working either. There we go. Can you all see that?
We can.
All right, thank you. So yeah, I just want to continue on with what Ken was talking about and go over a couple sort of interactive tools that we have on our website. There's one, both of these tools were designed with the help of folks from the National Institute for Standards and Technology. We have a tool that's focused on schools. It's a model. The model is a 790 square foot classroom that has one infected occupant inside the classroom for a total of 6 hours. And what this tool allows you to do is you can go over and you can pick your HVAC type. You can pick what ventilation enhancements you may have or you're considering implementing in the space. So, it gives you the option of no ventilation if you're just going to use open windows or whatever. It gives you the option of a terminal unit, which is typical in classrooms, sort of that under the window system like you see in a lot of hotel rooms. And it gives you the option for central and rooftop units. And then you can pick enhancements, whether you're using a portable HEPA filtration unit. If you've upgraded your filter, they assume a premium filter is a MERV 13 rated filter. You can go to 100% outdoor air if you just want to open windows. And if you want to implement an exhaust fan to help improve mixing in the space. One limitation of this particular model is you can only pick one enhancement at a time. But if you click on an enhancement over your baseline condition and you get an improvement, you choose another enhancement, you get an improvement over your baseline condition. You know that those two enhancements, if you implement them together, are somewhat additive. So, any improvement is better than none. We have another tool that's probably a little more useful in a lot of cases, but it's set up for homes, but it essentially just assumes a 1,000 square foot space, which is the average size of an apartment in the United States. So this space does not have to be a home. That's just what the graphics were set up to be. And again, this one gives you a little more variability in the options you can pick. You can choose whether your HVAC system is off. You can choose whether it's in the auto position where the fan cycles on and off based on your temperature setting, or you can turn your thermostat to the on position like Ken mentioned. So it's operating all the time. You can tell it if you're using an appropriately sized portable HEPA air cleaner. If you have what kind of filter you have, do you have just your standard filter? MERV 6 is the assumption for what's in a typical home, whether you've upgraded that to a MERV 13, and whether you're going to implement open windows in your strategy. So again, you can play with that and see what answers you get to help inform some decisions. What I really wanted to get into is a series of frequently asked questions, or FAQs, that we have on our webpage. There's currently 12 of them. You can see them here. I just want to go into a couple of them because we get an awful lot of questions on some of these. The first one is, can COVID-19 be transmitted through HVAC ventilation systems? Ken went through the science on how long particles can stay suspended in the air. And that can be quite a while in many cases. As it stands today, we don't have any definitive evidence that this is spread from one space to another through HVAC systems. Obviously, air currents within a given room, if you're blowing infected air over somebody else, can certainly help spread the disease. But there has not been a lot showing that this disease spreads through typical HVAC systems. Another question that we get quite often, particularly from healthcare, is how long will it take to dilute the concentration of infectious particles in a room once they're generated? Again, Ken went into some of this. Where people generally make this decision or make this determination is in the CDC's guidelines for environmental infection control in healthcare facilities in 2003. We have a table B1 in that document, and this is a snapshot of it. But essentially, in a given space, once you determine your air changes per hour, that's the left-hand column, what ACH stands for, your air changes per hour of clean, uninfected air, it'll give you the time required to reach either 99% cleanliness in the air or 99.9%. In general, 99% is enough. There are specific cases in healthcare, measles or tuberculosis, maybe where you'd want to go to the 99% range. But one thing I need to caution you on is that table comes with a footnote that everybody forgets. The values in the table assume perfect mixing, and perfect mixing very rarely happens. So you need to multiply the times that are in those tables by a mixing factor. And a mixing factor is very difficult to determine. It takes very specialized equipment, some experimental trial and error to get that number. So you usually just apply a safe rule of thumb. And in general, rooms with higher airflow rates, like 6 air changes per hour, with good placement of supply and exhaust grills, they have good mixing, and we typically give them a mixing factor of 3. So we'd have to multiply the time in that table by 3. Unventilated or poorly ventilated spaces can have mixing factors up to 10. So when you have a space, if you do the calculation right, you apply your mixing factor, you get a very unwieldy time that it takes to clear particles. You can reduce those wait times by increasing the air changes per hour, reducing the mixing factor, or implementing better mixing in the space, or a combination of both. And that FAQ has example calculations and an example problem on how to do that.
Steve,
what is a
quick
HEPA
question
filter?
for you.
Yes.
The presentation of your slide is very small. I believe you're in slideshow mode. Could you switch over to presenter mode?
I'm sorry about that. I don't even know how to do that. Is that any better?
So Steve, up at the top, just go into, if you go back to that previous screen and see at the top, it says slideshow, up and to the right, up a little bit to the right, more to the right.
Hang on, I got a thing blocking me. I thought that's what this did too. It's just not cooperating with me.
Okay, we can continue here. I know that the presentation will be available after, and our viewers can see more detail then.
Okay, yeah, I'm really sorry. It's just not working for me.
Thank you.
It's huge on my screen, but so anyway, what is a HEPA filter? Throughout the pandemic, everybody's talked about what a HEPA filter is. And by definition, HEPA filters are at least 99.97% efficient at capturing 0.3 micron particles. And one sort of myth that I want to put to rest here is you'll hear a lot of people, particularly selling other air cleaning products that they want to compare to a HEPA filter. They'll say that a HEPA filter is only good for particles down to 0.3 microns. That simply is not true. The 0.3 micron is the most penetrating particle size through a HEPA filter, so it is more efficient than 99.97% at filtering particles that are larger and smaller than 0.3 microns. So if you hear that, you'll know that that's false. So portable HEPA units, they're essentially just a fan with a HEPA filter. They're meant to put into space. They not only help filter the air, but they help increase mixing within a space. when you choose portable HEPA units, we recommend you use the clean air delivery rate method. The link to EPA's guide is there. Essentially, that's just a method of test from the AHAM that gives you two numbers. They'll give you a clean air delivery rate, and then we'll do a calculation based on the room size that your air cleaner would be good for in square feet. You need to keep in mind that does assume an 8-foot ceiling. So if you're putting an air cleaner in a tall space, you need to do a calculation to adjust that. And we go through that in our FAQ number 5. And one other thing that I want to point out is that depending on the size of the space, you don't have to just get one HEPA unit for that space. Sometimes it makes more sense to get 2 or 3 and spread them around the room, instead of having all that air being pulled and exhausted back into the space and in one corner setting. We get this question a lot. Does ultraviolet germicidal radiation kill SARS-CoV-2? All I'm going to say is yes. And it is extremely easy to kill compared to a lot of other airborne pathogens. So UVGI is certainly a technology to consider for SARS-CoV-2. What types of devices are available for cleaning and disinfection in the workplace? Ken touched on these. CDC recommends really 2, upper room UVGI. These are typical in healthcare waiting rooms. You'll see them in homeless shelters, in prisons and jails. This is where you mount fixtures high on the wall or suspend them from ceilings, so you create a very intense zone of UV over the heads of the occupants. So as the bugs mix around the room and go up into that irradiated zone, they're killed, but the people are exposed to only safe levels of UV. Induct UV is where you mount UV lights inside your air handling system or inside an air duct somewhere. I will caution you, there are 2 types of induct system. One is for coil treatment. So if you go into your local big box hardware store and you buy a UV light to mount induct, there's a 99.9% chance that is for coil treatment only, and it'll do you very little good for air disinfection. Air disinfection induct systems, they can be designed to be very, very effective and efficient, but they typically have to be custom designed for your HVAC system by qualified HVAC system designers. The other one I'll touch on, Ken mentioned this as far as an emerging technology. FAR UV is one of those technologies. It has become very popular during the COVID-19 pandemic. The 2 systems that I told you about previously use UV energy at 254 nanometers. FAR UV is a shorter wavelength down around 222. It appears that it is safer for people than we once thought, and it appears that it can be effective at inactivating microorganisms as well. This is probably the emerging technology that is further down the path to mainstream acceptance, but CDC is not to that point yet. So just be aware that it's out there. If you use it, there's some homework that you need to do to make sure you're convinced that it's going to meet the needs that you have. And that gets me to the last one I want to talk about. This is really our FAQ on emerging technologies. And it's important to note that CDC does not provide specific recommendations for or against any manufacturer or product. We will support specific technologies if they work, but we will not make any recommendations for or against a manufacturer or product. And as you're all probably well aware, there's been numerous technologies heavily marketed to provide air cleaning during the pandemic. Sometimes these technologies have been around for decades. They're just repackaged. So they didn't catch on the first time. They're going to see if they can catch on the second time. It's important to note that just because we consider you an emerging technology, that's not necessarily bad. It just puts more work on the consumer. So the consumer really needs to request testing data that quantitatively demonstrates a clear protective benefit and occupant safety under the conditions consistent with intended use. And that's very important because often you'll get test reports where The magic device was tested in a shoebox, and after 30 minutes, it killed everything. And now you're supposed to mount it inside an HVAC system moving 5,000 CFM of air. And you just can't take the testing results and apply it to real world use. So if you're going to consider some of these products, absolutely do, but make sure the manufacturers or the resellers can prove to you beyond a doubt that the products will be both safe and effective for the use that you have in mind. There's a list of FAQs again. We encourage you to go take a look at all those. One FAQ that we don't have yet that we're working on, DIY air cleaners, do-it-yourself air cleaners. I'm sure you heard of these. These are all the rage right now. We sort of follow EPA's recommendation that they do recommend them for use if it's the only thing you can get your hands on. They do not recommend them for routine use as a permanent alternative to products of known performance, so such as a portable Hepa air cleaner or something else. And CDC sort of agrees with the EPA statement there. Just quickly, if you're looking to make building improvements, the president announced his national COVID-19 preparedness plan back in March. Part of that is the Clean Air in Buildings Challenge. It has 4 goals. I won't read them right there, but if you go to the link, there is federal funding available to help make some ventilation improvements. And that is all I have. And I apologize for the slides again.
No worries. Thank you, Ken and Steve. Very informative. And what's interesting is now we're going to take a turn to Frederick, who's going to talk about lessons he's learned from healthcare systems abroad, which in some ways brings us full circle with the genesis of Stephanie's work. So with that, I'll turn it over to Frederick.
Thank you very much. I will, perfect, now I can share my screen. Just as, can you see my screen now? Perfect. Just as a quick introduction, very happy to be talking here today. We have, so Rensair has been doing indoor air quality solutions in Scandinavian healthcare settings for almost 20 years now. We're a 2nd generation family business and have been working with, in particular, Danish hospitals for a very long time. We've been active in the US for a couple of years now, and very early on got introduced to Leapfrog, and a big supporter of the great work that you guys all do. And we have joined the partnership committee at Leapfrog to help promote indoor air quality as a focus within healthcare. Stephanie, you touched on this right towards the end of your presentation, but I think, just as a high level intro before I jump into some of my observations, we do spend 90% of our time indoors, and indoor air quality, according to the EPA, is 2 to 5 times worse than outside. I think that's important for everyone to bear in mind. When we look at different particles that float around in the air, obviously when we talk about healthcare settings, we tend to focus more on virus, bacteria, so pathogens, but also anything essentially from PM 2.5 and down, so particles of 2.5 microns or less. There is a new study that came out of the UK a couple of months ago, showing a direct correlation between PM 2.5 in the air and lung cancer. These smaller particles penetrate the body differently and impact the body differently, and that's why we need to focus on how we manage that in indoor spaces. But I also wanted to flag this study that came out of Harvard that, when we talk about indoor air quality in healthcare settings, the focus is oftentimes only on pathogens. We talk about virus and bacteria, but also indoor air quality has been shown a particulate matter. There's a clear correlation between particulate matter in the air and cognitive ability. And a lot of the work we do with, for instance, corporate office space is improving air quality, not just to minimize the risk of pathogen spreading, but also improving overall wellness in a building. And then I wanted to spend a bit of time on, obviously we have gone through this pandemic now, and there has been different responses around the world to the pandemic on the back of it. and how that translates into ventilation. So the World Health Organization came out last year saying you should be ventilating significantly more in your buildings, should be doing a minimum of 10 liters per person per second in offices, schools, etc., which translates to roughly 21 cubic feet per minute. But for healthcare settings, those numbers are significantly higher. I think it's also worth noting that these numbers are on a per person basis, where many historically think of air changes per hour in a room as a function of the size of the room. Really, what you should be thinking about is how many people are in a space at any given time, and ensure there's sufficient ventilation for that amount of people. And you can see here that the recommendation for aerosol generating procedures is all the way up at 160. We've already seen the mention of the Clean Air and Buildings Challenge in the United States that came out earlier this year from the White House and the EPA, really to promote focus on indoor air quality and encourage building owners and operators to improve air quality. But when we look at Europe, we're seeing some of that already translate into new legislation. So in the United Kingdom, there's a clean air bill that essentially will demand improvements and increased ventilation rates in buildings. And Belgium have already passed new legislation, which means that within the next 2 years, we need all Belgian buildings need to upgrade and demonstrate they have upgraded ventilation in those spaces. So it's clear that this is on the back of the pandemic becoming a political focus as well, and changes appear to be coming across the board. So what I wanted to talk a bit about is some of the lessons we've had in working with, particularly with the National Health Service, so the NHS in the United Kingdom, and how they have approached. The NHS is one of the world's largest public healthcare providers. We have worked with them and delivered solutions to more than 50 different trusts, so groups of hospitals across the country. The first takeaway is probably not too surprising, but I want to mention it anyway, that different spaces, of course, require different ventilation, and today's levels might be insufficient. When you look at operating rooms or AGP spaces, etc., by all means, that is where focus has been on air quality, and those standards tend to be sufficient, assuming that the amount of ventilation that you expect to be delivered there is in fact delivered. But what we have seen the focus has been on is really, you can say, your standard patient rooms, hospital wards, and for instance, A&Es, where you have a patient enter with a respiratory illness. The time they spend in a poorly ventilated space can make a big impact, and that is something that we have seen many hospitals have chosen to focus on. We also have these convertible spaces in hospitals. So let's say, for instance, COVID wards that have been created specifically for this. Of course, they need to address ventilation. And to, you could say, in the context of what we've seen in the earlier CDC slides, it would be a very long process to address that through building upgrades. So the path that has been chosen has been these standalone portable solutions that have been supplied in those spaces. Also to a point we heard about earlier, older buildings do often not deliver the rates expected simply from as a result of age. So performance will drop off in equipment over time. There could be leaks, there could be poorly fitting filters or whatever else. And buildings tend to be built to a certain standard, and they meet those standards when they are designed. But it's unclear, and there are no clear rules or checkups on when reviews are made to ensure that these solutions continue to deliver what you would want out of them. Then we did a lot of work with the NHS on AGPs, and in particular dentistry and spirometry, where even if you have historically had a certain requirement around air changes in one of these spaces, we've seen that that might not be sufficient. And I want to share a couple of slides from a study we did that was really quite interesting with a research institution called ESI and then Birmingham University Hospital. So here in this study, you can see this is a standard dental treatment room from the hospital. This was mapped out. 5 air changes per hour was delivered to that space prior to this study. ESI then carried out CFD modeling, so computer fluid dynamics modeling of the space. They modeled the airflow from the existing vents and the 5 air changes that were being delivered. And a device was then introduced to the room to improve ventilation. So a Hepa device that added further circulation to the space. And here you can see in different scenarios, what does that mean for airflow? What does it mean for particulate matter being sent into the air? And how long does it take to remove all of that? And the conclusions here were, so 360 cubic meters per hour, that's 330 CFM for reference. It was demonstrated that with a device in the room that added to the ventilation, you can see the log 2 clearance on the right-hand side. So a 99% reduction in particles happens much, much faster as soon as you improve this ventilation. And this was a big focus with the NHS in the UK because the UK introduced fallow time between patients during the pandemic. So time where a dentist treatment room would be left empty for particles to fall to the ground. But with this data, essentially normality could be resumed because of the proof of how quickly a reduction of particles could be done in the room. Wrapping up here, what actions can we take similar to what the Clean Air in Buildings Challenge recommends? You know, we see that a lot of hospital systems, healthcare systems, are reviewing their existing ventilation now. Of course, we encourage everyone, as does this Clean Air in Buildings Challenge, to develop a plan for addressing shortcomings, but also focus on stakeholder education. It can be simple things such as opening windows, being aware of the air quality, and ensuring that whatever you can do can be addressed to ensure that you have a good indoor environment. Also, let indoor air quality be a differentiator. As Stephanie talked about earlier, you know, you can today quite easily measure and display air quality real time, so you can make the otherwise intangible tangible to the eye of people in a space, which will give reassurance. But also by upgrading ventilation in these spaces and showing the excellent air quality, everyone will know that it's a safe space to be in. And then finally, further researches and testing. There's a lot more testing that can be done here, a lot more trials that can be carried out. And what we are seeing now in the United Kingdom as well, and we are now starting to replicate some of that data in the United States as well with the work we do. But in the UK, NHS England and Liverpool University Hospital have just started a trial with us where 20 children with severe asthma are getting an air purification device in their house, in their home for a year, and to see the impact of better air quality in the space, where particulate matter removal and VOC removal will be key, and then looking at those results with a view to expand this into a larger study with a larger number of participants to really start showing in this case lower income housing what is the impact of good air quality and how does that trickle down into fewer infections and less time in hospitals. And then finally, yes, there's a lot more IAQ innovation and technology that is happening. There are a couple of these, you could say they're the well-known technologies out there, but in terms of innovation, where we are seeing the spaces moving is really how can you use modern technology to optimize your ventilation at any given time, and doing that while also keeping energy consumption in mind. So you ensure that you have sufficient ventilation for any space you're in at any time. So I'll stop at that, and I guess we can move to Q&A there.
Wonderful. Thank you, Frederick. Recognizing that we just have a few moments left, do want to turn to some questions. There were questions in the chat. Thank you all for posting those questions. I see that they have been answered in real time, which is fantastic. What I do want to turn to, though, is going back to Stephanie. You had mentioned kind of indoor air quality and how it supports human health. And I think we've heard about that now from all of you on the panel. But I'm curious, how does managing indoor air quality to support human health differ from traditional Ashrae guidelines?
So that's a really interesting question. So Ashrae, and actually a lot of what we've heard here today is talking about the risk of exposure to, say, viruses or to gases or particles. And for those people who work in this space, the Wells-Riley equation is something that's used to predict exposure risks. But what's missing from that approach, and which managing indoor air quality for human health includes the impact of the indoor environment on your immune system, on inflammation. You know, Patrick mentioned CO2 and cognitive performance, but if you expand the impact of the indoor environment from cognitive performance to the impact on all of your physiological systems, it's really interesting, but it's also slightly different from just looking at exposure risks. One of the big differences is, you know, the need for water vapor in our spaces, which is known as relative humidity or humidity, which is generally a concept that is sort of shied away from in many different climactic areas for reasons having to do with the building envelope. But it's just a different approach. The output is very similar, but not exactly the same as risk management.
Thank you. And Ken, now I want to turn to you because I'm curious your thoughts on how kind of ventilation guidelines, how it applies as it relates to Standard 170.
Sure. Yeah. Well, you know, for healthcare environments, which I understand most of this audience is, that's what they're concerned with. The prescriptive requirements of Standard 170, I think, are fairly well known, but it's important to remember that they don't apply to every space within your healthcare facility. And that's especially so if you're looking at outpatient kind of spaces. So the kind of interventions that we've been discussing here in a lot of ways are for those other spaces. Even patient rooms within a traditional patient room does not have an overly prescriptive ventilation rate. And so there's opportunities to improve ventilation within those spaces using some of the recommendations that were presented. Especially true for outpatient spaces, especially true for surge spaces that are being converted for infectious aerosol patients, treatment rooms, triage screening, urgent care. One of my favorite ones is the waiting area at an urgent care clinic. You know, there is no special ventilation requirement for the waiting area at urgent care, none whatsoever. It's relatively follows the same guidance as a office environment.
So then this kind of takes us to this conversation of, we have all of these older buildings, right? So in terms of retrofitting those buildings, I'm curious, Frederick, what are your thoughts there on ways to improve indoor air quality for older buildings?
I think you have a number of different options, right? But what you need to balance is time to implement that, and of course the feasibility of that. When you have older buildings, a lot of the work that we do is with you know, standalone devices that you can implement in spaces where that's otherwise not feasible. It was interesting. We have learned from, again, returning to the NHS, that more than 50% of their overall buildings do not have historically have easy access to fresh outside air. They can only open windows, for instance. So they are now, you know, with European winter coming and the energy crisis that's happening in Europe, right? They need to find ways to manage ventilating spaces where the heating bills are going through the roof. So again, doing in-room installations is oftentimes you could say a good approach from a risk mitigation point of view, but also is very easy to implement and comes without some of the other challenges with retrofits.
Thank you. And Steve, I will leave the last question to you as we are at the end of our time. But I'm curious here. I can imagine that many of our attendees have sales reps that come to them all the time and are telling them that they need to install devices, potentially to disinfect the air. How do they know if it's safe and effective?
I mean, that's an excellent question, and it gets right back to our emerging technologies FAQ. You know, we've seen countless stories throughout the pandemic of, you know, school district A buying millions or billions of dollars worth of these technologies, and then something bad comes out in the press about them and they're not being used. Unfortunately, the onus falls on the consumer to do their homework. So, you know, take the information that the manufacturer gives you, but take it with a grain of salt. You know, ask for third-party testing results. Ask for peer-reviewed journal articles where their product was used. You know, ask for safety studies that were done on you know, preferably, you know, in real spaces with real human occupancy. I mean, make them prove beyond a doubt that the technology they're selling to you is going to do what you want it to do. And if they can do that, and you know, there may be some that can, as I said, just because you're emerging doesn't mean there's something wrong with a technology. It just means that we don't have the historic knowledge base to go on for those technologies. But if they can prove it to you, then consider it. If they can't, or if they're unable to answer some of the questions you have, then maybe you need to look at more of a proven technology.
Maybe just to add to that, in our experience, what we see in healthcare, right, it's oftentimes the infection prevention and control teams within hospitals that will do that review of technology. So I think, you know, in that sense, and I noticed there was a question in the chat as well before, it's then often the facilities teams that implement, but the review of technology sits with the infection prevention and control team, and you know, they tend to be very, very good at what they do and have the ability to review all this independent data. Whereas, you know, when you move outside of healthcare, oftentimes, you know, if it's other consumers, they don't have necessarily the background to understand all this, you know, independent data that they get presented with, and whether it's independent or not.
All right. Well, with that, we will close. Thank you all. Certainly want to thank our distinguished panel of experts today. We did learn a lot about clean air and its significance in protecting our community and keeping us safe. Thank you for your time, and thank you to all of our attendees. Have a great rest of the day.
Thank you.